This is our final epidemiology project.
The first chapter deals with cohort studies. A cohort study is when an investigator selects an exposed group and a non-exposed group of individuals and follows both groups forward to compare incidence of disease or rate of death from disease. If an association does exist, then the number with disease in the exposed group, A over A plus B, will be greater than the number with disease in the non-exposed group, C over C plus D. A cohort study is warranted when there is some idea of which exposures are possible causes of diseases so that the investigators have something to focus on. Cohort studies also work better if there is a shorter period of time between exposure and disease. Note that when choosing participants, it is important that exposed and non-exposed groups under study be as similar as possible with regard to confounding factors. Also note that a major problem from lack of randomization in a cohort study is the possibility that a factor that led to the exposure rather than the exposure itself might have caused the disease. There are two types of cohort studies. A prospective cohort study is when the investigator identifies the population at the beginning of the study and follows forward. The advantage is that several exposures can be studied at once, but the problem is that these studies take a very long time to complete and are difficult to get funded because they are often very expensive. The second type, a retrospective cohort study, is when the investigator ascertains exposure from past records and outcome is ascertained at the time the study began. Note that the sample size required for each study is similar. There are several potential biases in cohort studies. Bias in the assessment of outcome is when the person assessing outcome is aware of exposure status and hypothesis of study. Control this by making the person making the disease assessment blind to the exposure status. Information bias is when the quality of the information is different for exposed versus non-exposed groups. This is especially true of historical studies, i.e. when a group with a disease has more procedures done. Non-participation can also introduce bias. If people with disease are lost, incidence rates become harder to interpret. Analytic bias occurs when statisticians introduce their own preconceptions into the data interpretation. And that concludes cohort studies chapter.
Using the case control study model, Alden Oshner was able to link smoking to lung cancer, and Sir Norman Gregg was able to relate maternal prenatal rubella exposure to unusual cataracts in newborns. Case control studies like these compare a group of cases with a disease of interest to a non-disease control group with regard to a studyable variable like smoking in the case of Oshner. An important element of a valid case control study is selecting an appropriate control group representative of the population being studied. If the population being studied is a non-hospitalized population, control subjects can be enrolled in the study by the neighborhood approach, the random digit dialing approach, the best friend control approach, which are all ways to find a control subject similar to the case subject. Hospitalized populations are easier to contact and therefore study, but often cannot be non-representative of the community trying to be studied. It is important to match case control study subjects between the disease cases and the control group regarding such factors as age, race, socioeconomic status, and occupation, so the exposure being studied is the only critical difference. Approaches include group matching, which uses percentages such as marriage rates to match the two groups, or individual matching, in which similar controls are selected on a case-by-case basis. Unfortunately, issues related to recall can decrease the validity of case control studies. Limitations in recall related to the limits of standard human memory capabilities often make patients poor historians for key facts related to their case and the study. Recall bias can also complicate studies of this type because the disease group will, by nature of their illness experience, have a more vivid and detailed recollection of past, potentially insignificant events, such as minor upper respiratory infections, that the control group may not recall as readily.
Case control studies may use multiple controls with a single experimental group. This is often done in case control studies because it doesn't increase the amount of disease patients studied, which is often a source of increasing costs in the study. If multiple controls are done, the study may use controls of the same type, or different types. If controls of the same type are used, then only the ratio of the control groups to the experimental groups is changed. If controls of different types are used, then different factors can be controlled for in the study. This can help to provide multiple potential factors associated with disease, or it can help to isolate a single factor associated with the disease. In either case, it is common in such studies for the investigators to focus on a single factor which is most likely to be associated. Case control studies are often done to find out whether an exposure is associated with the disease state. Case control studies are often done prior to cohort studies because they are less expensive and can be done more quickly. Nested case control studies are done for similar reasons to case control studies. They are less expensive than a cohort study and can sometimes be carried out more quickly. Important distinctions between nested case control studies and regular case control studies are that nested case control studies reduce recall bias because the participants are interviewed at the beginning of the study before disease has developed. For the same reason, any exposure is known to be prior to the disease state, which is not true of case control studies. Finally, nested case control studies are often less expensive. The reason is that only the study participants who develop disease or are selected for the control group are evaluated for exposure. In other words, a blood test would not be done for everyone as in a cohort, but only for those eventually put into experimental groups and a control group. This is often done through freezing specimens until a later date when some participants have developed disease. Cross-sectional studies are conducted by simultaneously testing a group for the prevalence of a disease and evaluating for an exposure of interest. This is done to find a potential associated factor with the disease which might turn out to be a cause or effect. Cross-sectional studies do not provide any data on the incidence of a disease and instead show the prevalence of a disease in a population. Therefore, they are called prevalence studies. To determine whether there is an association between an exposure and a disease, one can compare the prevalence of a disease in groups that had the exposure and did not have the exposure, or one can compare the exposures in groups that have the disease and do not have the disease. The causality cannot be determined in a cross-sectional study because the temporal relationship between exposure and disease is unknown. To determine causality, a case control study or cohort study would need to be conducted.
Now that we have defined the different types of studies, we now want to be able to interpret that data. We want to estimate risk. Absolute risk is defined as the incidence of a disease in a population. This does not indicate whether the exposure is associated with an increased risk of the disease. Thus, there is no explicit comparison, but there is an implicit comparison value. But how do we determine whether there is an association, which is what we are really interested in? That brings us to relative risk. Relative risk is defined as the risk in exposed divided by the risk in non-exposed. If relative risk is equal to 1, there is no association. If relative risk is greater than 1, there is a positive association, which means that there is a greater risk in the exposed. If it is less than 1, there is a negative association, and that means there is less risk in exposed. So relative risk can be used for the cohort study, as incidence data is available. But what do we do in a case control study? Odds ratio is something that we can use for both a cohort study and a case control study. For a cohort study, odds ratio is defined as the odds that an exposed person develops disease divided by an odds that a non-exposed person develops the disease. For a case control study, the odds ratio is defined as odds that a case was exposed divided by odds that a control was exposed. The odds ratio is interpreted the same way as relative risk is. If equal to 1, no association. Greater than 1, a positive association. Less than 1, a negative association. So when is odds ratio a good approximation of relative risk in case control study? There are 3 parameters: when cases studied are fully representative of population, when controls study are fully representative of population, and when the disease being studied does not occur frequently.
Moving on to Chapter 12, attributable risk is the amount or proportion of disease incidence that can be attributed to a specific exposure. It is more important than relative risk in a clinical and public health setting. In regards to calculating attributable risk, the incidence due to exposure is the exposed incidence minus the non-exposed incidence. The risk proportion due to exposure is the exposed incidence minus the non-exposed incidence over this risk in a population. The principle is just the same, but you need to substitute the incidence in the exposed group for the incidence in the total population. Sample calculations are shown on the slide. Population incidence is the exposed incidence times the percent of the population exposed plus the non-exposed incidence times the percent of the population unexposed. Population risk due to exposure is the population incidence The importance of this to the physician is to be able to convey to their patients how certain behaviors increase their risk of certain health outcomes. For example, smoking and congestive heart failure. When reviewing treatment options, to be able to understand the benefits of one treatment over the other. For example, patients with high cholesterol on statin A had a 45% chance of myocardial infarction, and patients on statin A and medication B had a 40% chance. The table above just summarizes the calculations talked about on the previous slides. Chapter 13 is a review of cohort and case control studies. Much of the information from this chapter has been incorporated in the previous slides, but just a couple things to highlight. Cohort studies are desirable when the exposure of interest is rare. They compare exposed and non-exposed people, but they require large populations and are expensive. Case control studies are desirable when the disease occurrence is rare. People with the disease are, are compared to those without the disease, and they are inexpensive and require a relatively small number of subjects. Recall bias does occur with cohort studies.